Thank you very much, and thank you again for inviting me to the conference. So my topic is a controversial one, as you've said. Are we overdiagnosing and overtreating GDM? But the two kind of interrelate, because if we overdiagnose, by definition, we're overtreating. So the question is, how should we diagnose, and what criteria should we use? So I have no real conflict of interest, except, of course, I was the chairman of the NICE Guideline Development Group, so I am going to talk about the rationale behind the criteria which we developed. Now, in the UK, around about 700,000 women deliver in England and Wales, and diabetes is the commonest medical problem that we have to deal with, affecting about 4.5, although that percentage will vary depending on where in the country you work and the ethnic and other background of the women who are in the clinic that you serve. Now, in Southeast Asia, according to the Diabetes Atlas and Review in Diabetic Medicine, around 25% of all pregnancies will have a degree of glucose intolerance, and 86% of those will be diagnosed as gestational diabetes. So it is, as you say, a big problem and a big concern. And this is derived from the table from the Diabetes Atlas. And as you can see, Southeast Asia, which includes India and let's have a look. Yeah, here we go. Southeast Asia is highlighted in red, and the age-adjusted prevalence is said to be about 26.6%. But this, of course, depends on your diagnostic criteria, and these are not gone into in any great detail in the atlas, so it's self-reported gestational diabetes. So, first question then, are we overdiagnosing gestational diabetes? Is it right that a quarter of all women have an abnormal condition in their pregnancy? So we need to go back, if you like, using Socrative reasoning as to why do we need to diagnose diabetes at all. And I would say that most of us would agree that we diagnose diabetes to identify those at risk of the complications of the condition, and then we want to intervene to prevent those complications from occurring. So, for example, in diabetes out with pregnancy, in diabetes in the general population, we diagnose it based upon the risk of retinopathy. Now, I don't know of any other condition where we take a population, look at the blood glucose, look at a blood parameter, look at a complication, and then work backwards to diagnose a condition other than diabetes, because that's exactly what we do with diabetes. We take retinopathy, which is virtually specific for diabetes, and then we look at what level of blood glucose is associated with retinopathy, and that becomes diabetes. And that's what's happened. These are Japanese data, but you can see fasting plasma glucose, 2-hour plasma glucose, and so on, and you'll see that there's a big kick-up in retinopathy prevalence at around a fasting plasma glucose of 6.2 to 6.8 millimoles per litre, and a 2-hour between 9.2 and 12.4, and then the WHO decide on which level we're going to call diabetes. But of course, you can get retinopathy below these levels. It's just that the risk is lower. And this is what we have to keep in mind. When you have a parameter with a range, you take a cutoff point, and by definition, there is some arbitrariness to where you make that cutoff. And you have to use some sort of decision tool to help you. So for diabetes, generally, retinopathy is a serious condition. We have good treatments, as we heard about yesterday, so it makes sense to diagnose it based upon blood glucose levels associated with the eye complications. Now, in pregnancy, glucose intolerance or abnormalities are associated with a whole range of complications, and that can be due to pre-existing diabetes. There's miscarriage, congenital malformation, stillbirth, neonatal death, And in gestational diabetes, you have these other complications, and then both conditions are associated with this whole range of complications here. And so there's no doubt that glucose intolerance in pregnancy is associated with complications. The question is, at what level does that occur? And many of you will be well familiar with a landmark study called the HAPO study, which was published now over 10 years ago. And sadly, unlike retinopathy prevalence, there is no cut point at which blood glucose levels in the woman are associated with the complications of pregnancy. It is a linear relationship. So that gives us a real headache, because we need to know at what point do we intervene or label a woman as having gestational diabetes. And for that, in order to help us, we need good trial intervention data. Now, we do have at least 2 very good trials, and these were game changers, really, because up until the publication of these trials, there were 2 extreme points of view. There was one that we shouldn't even worry about gestational diabetes because we've no evidence that it makes any difference in terms of management. And on the opposing side, we've got a situation where everybody was being treated. And of course, gestational diabetes, as originally defined, was based upon the maternal risk of developing type 2 diabetes after the pregnancy and many years later. So we needed data based on intervention and fetal and maternal outcome. And the ACHOI study was published in 2005 from Australia. And these were the first real data to help us in deciding whether or not we should be intervening in gestational diabetes, the best data today. But their entry criteria were a fasting plasma glucose of less than 7.8 and a 2-hour between 7.8 and 11. So this is pretty extreme hypoglycemia by current standards. And these were the target ranges of blood glucose in the women in the intervention arm who met these criteria. And the total, there were 490 women in the intensive arm and 510 in the control arm. The second study was one performed in the USA by Landon, similar numbers of women to ACHOIS. This time the entry criteria used a 100-gram oral glucose tolerance test with these levels of blood glucose, which are very, very similar, in fact, to the levels in the current definition. I'll come back to that later on. The target range in this case was a fasting less than 5.3 and a 2-hour postprandial less than 6.7. Now, both of these trials, when you perform meta-analysis, definitely showed that intervention did reduce the various complications of pregnancy, including serious perinatal complications, macrosomia, preeclampsia, cesarean section rates, etc. So, based upon the data suggesting that intervention could help, and based upon the HAPO data, a consensus panel was convened and published in 2010 what were called the IAD-PSG criteria for the definition of gestational diabetes. And these were subsequently adopted by the WHO in 2013. And these were based upon the odds ratio of a 1.75 for a greater than 90th centile for large for gestational age, cord C-peptide, and fetal percent body fat in the HAPO cohort of 25,500 pregnancies. They also advocated universal screening, but there was no clinical or cost-effectiveness analysis performed, and it was reached by an expert panel. So when we decided in the UK that the diabetes in pregnancy guideline needed to be reviewed, With regard to gestational diabetes, we had to ask two main questions. What were the glycemic thresholds that would justify intervention on clinical effectiveness and cost effectiveness? And should we adopt a universal or a targeted screening approach? And we've been much criticised in NICE because we focus hugely on cost effectiveness. But when you've got a finite health budget, you have to make a line somewhere. And I'm going to try and justify why we adopted the criteria that we did. So we adopted a modelling approach, and we used 3 data sets on which to model the effectiveness of different thresholds and criteria for the diagnosis of gestational diabetes. And the 3 data sets we had were from a large population of women who were looked after in Norwich in East Anglia, the eastern part of England. And they were screened routinely between 2008 and 2014 with a glucose tolerance test. And they had risk factors for gestational diabetes, and also additional risk factors including polycystic ovary syndrome, previous stillbirth, and recurrent glycosuria. We used the data sets from 4 HAPO centres, 2 in the UK and 2 in Australia, and we were very grateful to those centres for allowing us to use their data. And then we also used data from Fidelma Dunn from the west of Ireland, from the Atlantic Diabetes and Pregnancy Study called the Atlantic DIP, and she also gave us access to her raw data set. This is a complicated slide, but what I want you to concentrate on is this diagnostic threshold column here to my left and your right. And basically we looked at no treatment at all, different levels of fasting and 2-hour plasma glucoses. We looked at the IAD-PSG where the odds ratio was not 1.75 but 2.00 from the HAPO data set. We looked at the original WHO criteria from 1999. We then looked at another range of fasting and 2-hour values. We looked at IAD-PSG 1.75, 1.75 including a 1-hour sample, which is the current WHO 2013 criteria, and then we looked at an even more stringent criterion, which was 1.5 odds ratio. And the next columns talk about the cost, the quality adjusted life year, and the life year, and the incremental cost effectiveness ratio. Now, strictly speaking, NICE adopts a threshold of £20,000 for effectiveness, but in certain circumstances that can be adjusted up to £30,000. And in our original analysis, and this is taken from the full NICE guideline, we found that even using the criteria here, the cost effectiveness ratio was above £30,000. Despite that, these were the criteria that NICE adopted, and I'll come and explain in a little bit more detail why that was. So that was a fasting plasma glucose of 5.6 millimoles per litre and a 2-hour value of 7.8. Now, we revised the cost effectiveness data in a recent publication in BMJ Open in 2017, and what we did is we compared directly in this analysis using the HAPO 4-centre population that I mentioned to you earlier with the NICE 2015 diagnostic criteria and the WHO 2013 criteria. And the NICE criteria had a fasting glucose, as I showed you, of 5.6. The WHO is 5.1. The 2-hour value in NICE is 7.8, and in the WHO it's 8.5. And what we showed was that the ISA, with this reanalysis and using more up-to-date information about 2 or 3 years after NICE was published, the ISA reduced to £23,073, whereas the WHO criteria, based on the HAPO population of 3,500 pregnancies, was 37,669. So we felt that we could justify this to the NHS on a cost-effectiveness basis, and I'll show you what the difference is in just a moment in terms of number of cases detected from the two criteria. The situation in India was very nicely summarized on Friday afternoon by Jayashree. So I'm going to quickly go through this, but currently, from my reading anyway, and forgive me if I've got this wrong, but the Diabetes and Pregnancy Society of India suggests a 2-hour post-75-gram glucose tolerance test, non-fasting, of a greater or equal to 7.8 or 140 milligrams per deciliter. Now, the prevalence estimates from a review in Acta Diabetologia in 2018, and again, I apologize if these are not quite up to date, suggest that the WHO criteria in India would diagnose 19.2%, which is a bit less than the 26% in the Diabetes Atlas. The original WHO criteria, 10%, and the DIPSI criteria were down at 7.4%, which to my mind seems possibly a little low, certainly based on our experience in the Asian population in the UK. So are we over-treating GDM? Well, the answer is it depends where you take your cutoff. If we go back to this level and at 7.4%, the answer is almost certainly no. With the WHO criteria at 19 or 20%, the answer might be yes, but it depends on what you can afford and what you think is a reasonable cost on cases found. And what I want to do here is explain to you what happens in our BMJ modelling in our three populations. So here we've got Norwich, we've got the HAPO, and we've got HAPO with risk factors as defined by NICE for gestational diabetes, and those without any risk factors, or the entire population. Then we've got the Atlantic dip population, which is the entire population, those with risk factors and those without. As I told you already, the Norwich group already were selected because they had NICE defined risk factors. So using our NICE criteria, 7% of the women in Norwich would be, who had risk factors would be diagnosed with gestational diabetes. In the HAPO population, the whole population, it would be 14%. In those with risk factors, 17.7%, so a good bit more than Norwich. Without risk factors, it would still be 8%. In the west of Ireland, the figures are even higher, 13% for the entire population, similar to HAPO, but 25% in the risk factor designated population, and nearly 6% in those without risk factors. But if you use the WHO criteria, across the board, the numbers are much, much greater. And so for HAPO population, it would be 25%, and for the Atlantic dip population, with risk factors, nearly 40% of women would be diagnosed. What does that mean in terms of complications from pregnancy and what the intervention would do to reduce them? Well, here we've got the number of women diagnosed with gestational diabetes. We've got here SD, which stands for shoulder dystocia. SPC is serious perinatal complications, death, shoulder dystocia and birth trauma. CS is cesarean section. NICU is an admission to the neonatal intensive care unit. This is neonatal jaundice. And P is preeclampsia, and IOL is induction of labour. So, using the HAPO population with risk factors, which is around 3,500 women, with no treatment, these would be the number of cases that you would get of each of these complications. Using the NICE criteria, we would diagnose 629 of those 3,549 women with gestational diabetes. We would reduce the shoulder dystocia from 49 to 41, the serious perinatal complications from 67 to 56, cesarean section rate by 20 from 759 to 739, NICU admission from 345 to 326, jaundice reduction of 9 cases, Preeclampsia, a reduction of 23 cases, and there would be an increase in the induction of labour by 30 cases. If you use the WHO criteria, you increase the number diagnosed by almost 50% to 912 women. You would reduce the number of shoulder dystocia cases by 2, serious perinatal complications by 2, caesarean section rate by 8, NICU admissions by 5, jaundice by 3, preeclampsia by 6, and you would have an extra 12 inductions of labour. So it's a decision to be made by the healthcare provider whether an increase in the number of cases by 50% and the reduction in complications by these numbers is overtreatment or not. So how do we treat women who have a label of gestational diabetes? And in the current NICE guidance says, and this is pretty typical of many international guidelines, dietary advice, lifestyle advice. You've got to exercise more, you've got to go on a diet. Well, that's okay, but if you've got other kids and a family at home, it's not always easy to do all of these things, but most women try their best. Then you've got to measure your blood glucose levels 4 times a day. Well, that's a bit of a nuisance and also uncomfortable. And then the targets are fasting less than or equal to 5.3 and a 1-hour post-meal less than 7.8. Then you've got treatment with metformin, plus or minus insulin, as we heard about on Friday. You've got more surveillance, more fetal ultrasound. You have risks of hypoglycemia, which if you've got a young family or you're driving or you've got you're working, that can be really inconvenient. And of course you have enormous anxiety and stress. And I believe that gestational diabetes, from all of my experience, is absolutely not a trivial diagnosis for the woman that's affected. And we need to be very careful about making the diagnosis and talk to them about what the benefits and risks are of giving them such a label. So, how can we round this up? Well, are we overdiagnosing or overtreating? Well, it completely depends upon the diagnostic criteria. And because of the linear relationship between blood glucose levels and maternal and fetal complications, every individual society has to decide where it draws that line based upon some sort of criterion. And it comes down, I think, to pounds and pence to a large extent. If we had an unlimited budget, sure, let's adopt the WHO criteria. As we don't have an unlimited budget, we have to draw the line somewhere. All costs should be considered. So not just financial, we have to look at the personal costs to the woman. And is it right that we put so many women through a treatment pathway for gestational diabetes to reduce a few cases of complications? Now clearly for those individual women, those cases of complications are really, really important. But it's all the other women who are not going to get those complications which we've also got to consider. Now when WHO published their guidance in 2013, and I'm quoting now from that paper, they said that a substantial body of new data will emerge in the near future providing currently scarce health and economic evaluation of the recommended criteria applied to various populations and with various approaches. Universal screening, screening women only at high risk, and diagnostic testing only. And I'm hoping that the NICE process has contributed as the WHO required. And it's part of a debate. I'm not saying that NICE is right, WHO is right, anybody is right. What we have to do is have a sensible debate about what we can and can't achieve for our women and decide on the criteria of diagnosis of GDM and the effective treatment based upon those discussions. Thank you very much.
Thank you. Please come and join us.